جود مورنينج، صباح الخير. في البداية أحب أشكر أستاذ دكتور إيمان عيادة وأساتذتي الأفاضل على الدعوة الكريمة للتقديم النهاردة في مؤتمر اسم نيوناتولوجي جامعة القاهرة مستشفى أبو الريش بيتنا الكبير. Today I'm going to take you through a few cases to highlight the roles and the challenges of genetic testing in the perinatal period and how to deliver that from the lab to the bedside. As we know, testing can be targeted, which means that we test for a single gene or gene panels, or can be genome-wide, which means we test for gene alterations or changes across the genome, such as the microarray test, where we look for microdeletions or microduplications across the whole genome, or clinical exome, whole exome and whole genome sequencing. Targeted testing is very useful in the clinical situations when we can link the phenotype strongly and confidently to one or few genes. And in this case, it can be less costly and has a quick turnaround time. And also there is less chance of finding or identifying variants of uncertain significance, which are gene alterations that we are not very certain or clear whether these are disease-causing or pathogenic or part of the normal human genetic variation or benign. However, it's not suitable if the phenotype is non-specific or linked to numerous genes, such as developmental disorders, structural abnormalities, and other indications. And this is where genome-wide testing would step in to be the best diagnostic tool. And it allows us to obtain a diagnosis in such patients with non-specific phenotypes. And also it increases the chances of identifying novel genes. However, it's quite costly and could have a longer turnaround time, despite that now there is increased availability of urgent microarray and rapid whole exome and rapid whole genome testing, which can deliver results in few days or few weeks. There is also a higher chance of finding these variants of uncertain significance, which can be challenging in variant interpretation and assessment. And we can see here that the yield of diagnosis for whole genome sequencing can be quite variable depending on the phenotype, being high with things like neurometabolic disorders, certain epilepsies, clinical disorders such as osteogenesis imperfecta, but being quite low in other non-specific disorders such as autism. And so genome-wide testing is not the magic tool for diagnosis. We have to build a puzzle for holistic approach between clinical and genetic. The first case is about a patient with neonatal epileptic encephalopathy. This patient is a second child to non-consanguineous parents. Family history is irrelevant apart from a history of 2 miscarriages. Antenatally, the prenatal period was unremarkable, but there was some increased fetal movements towards delivery. The baby was born at term by elective section, and at birth, thick meconium was noted. However, the baby was born in a good condition initially. At about 3 minutes of life, the baby developed cyanosis and hypertonia and rigidity. She required inhalation and ventilation presses, transferred to NICU and requiring CPAP ventilation initially. And then the baby developed seizures in the form of multifocal clonic and myoclonic seizures. These did not respond to loading doses of phenylpalmitone and phenytoin and a loading and maintenance dose as well of levetiracetam. The patient was mechanically ventilated and placed on continuous cerebral function monitoring, or what we call amplitude integrated EEG. And at this point, there was the question, is this hypoxic ischemic encephalopathy? There is a history of thick meconium. The baby deteriorated immediately after birth within a couple of minutes. So is this that or not? We know from previous studies that hypoxic ischemic encephalopathy is the most common cause of neonatal epilepsy, followed by infarction and hemorrhages. However, CNS malformations, infections, metabolic and genetic disorders still has a role. And generally, if we have a critically ill baby with abnormal movements, we should put on video EEG or amplitude EEG so that we can know whether these seizures are actual seizures or other movement non-seizure disorders. And in this instance as well, we can see whether this is electrographic seizures or clinical as well. And we can see on the right, there is a long list of conditions which can present with neonatal rigidity. And with that, there is infections, metabolic conditions, genetic conditions. So the differential diagnosis here remains wide. The baby had an EEG It showed frequent multifocal sharp waves and the nearest status epilepticus on the amplitude EEG. CT brain showed cerebral atrophy with wide extracerebral spaces, and the same on MRI as well, with some dilatation of ventricles and dilated extra-axial spaces. There's been marked reduction in the white matter volume and some distorted configuration of the sulci, but the cortical folding was mature in general, so no pachygyria, no lysencephaly. The corpus callosum here, as we see on the bottom left, is thin and slightly short, and there is increased signal intensity on the posterior brainstem. Overall, the interpretation of this result that there is no overt signs of severe perinatal hypoxic ischemic encephalopathy. There is preservation of myelin in the posterior limb of the internal capsule, which we can see here, and the normal size of brainstem makes antenatal hypoxic ischemic insult unlikely. And overall, neuroimaging suggested a genetic condition. Other assessment included ophthalmology review, which was normal. Post-screening for congenital infection didn't show any abnormalities. Clinical examination did not show any overt dysmorphic features. And it was decided that we should start on urgent biochemical and genetic investigations in parallel. In this situation, we cannot start step-by-step investigating this baby. The baby is in a critically ill situation, so we had to start in parallel and very urgently. On the meanwhile, the baby was started on carbamazepine and clonazepam with no response, as well as a therapeutic trial of pyridoxine, biotin, and folimate to look for a treatable metabolic epilepsy, again with no clinical or EEG response. Baclofen was started as a muscle relaxant, and ketogenic diet was started with minimal response. These biochemical tests were arranged, and overall, we didn't show any abnormalities. Again, I'm not going to go through all this list, but this is a list of investigations we would consider if we have a baby with suspected metabolic epileptic encephalopathy. And all of these were unyielding, including blood, urine, and CSF studies. Genetic testing here consisted of, three different tests, but it's very broad. Microarray to look, as I said, for deletions and duplications, or what we call copy number variants. Rabbit trio whole genome sequencing by testing the baby and both parents to look for single nucleotide variants in the nuclear genome, and also because we could not exclude mitochondrial disorders despite normal plasma and CSF lactate, we had to do mitochondrial DNA sequencing as well to look into mitochondrial DNA variants. Both microarray and mitochondrial DNA sequencing were normal. What about the rabbit trio whole genome sequencing? It showed compound heterozygous PRAT1 missense variants. Compound heterozygous means that there is two different variants on both gene copies that are different. If we say homozygous, then this means that the two variants are the same. And we know that biallelic pathogenic PRAT1 variants cause PRAT1-related neurodevelopmental disorder. We can see this variant here on the Decipher database, and the other variant here as well. PRAT1-related neurodevelopmental disorder is a spectrum of clinical syndromes which can vary between lethal neonatal rigidity and multifocal seizure syndrome to neurodevelopmental disorder with cerebellar atrophy and with or without seizures. In the most severe form, the lethal neonatal rigidity and multifocal seizure syndrome, patients have early onset multifocal seizures, rigidity, and microcephaly. Again, most of the features fitted the child, but the baby didn't have microcephaly at birth. And these patients usually would die during infancy. But sometimes in the less severe forms, they can have longer survival and later onset seizures. And we found from previous studies that neonatal onset of seizures was invariably associated with worse prognosis in early distant infancy. These are MRI from previous reports. We can see marked cerebellar atrophy. This was not seen in our patient, but this is a very rare disorder. About 40 to 50 patients describe in literature. So it's something that we will continue learning and understanding about. And epilepsy in some individuals showed a favorable response to ketogenic diet. In our patient, this didn't happen, unfortunately. A multidisciplinary meeting with the parents, neonatology, clinical genetics, palliative care, and pediatric neurology happened. And all these kind of aspects were discussed, and the parents decided that transition to comfort-focused care rather than continuing with active management was the kind of the plan to go. And this was quite a difficult decision for the family, and everyone in the MDT had to be supportive. But despite this condition being untreatable, still obtaining a genetic diagnosis in a timely manner allowed for decision making and management. We kind of decided that, yes, ketogenic diet trial was something to do, but this helped us to understand that with this not working, we don't have too many tools. This also allowed for accurate recurrence risk estimation for the family. So these parents have a 25% recurrence risk in a future pregnancy. And to prevent that, the family was offered family planning options, including prenatal invasive and non-invasive testing and pre-gestational testing or diagnosis. And this also provided closure to the family. And this is a very important aspect in patients with these lethal ultra-rare disorders. It's important to give them an answer. Why did my baby have this condition? What is the cause? This really gives them a lot of psychological relief and also decreases the sense of guilt in the parents. The second case is a floppy infant, distinctive features. So this was the second child to non-consanguineous parents. Again, the family history was unremarkable. Antenatal period was remarkable for polyhydramnios. The baby was born at term by elective C-section, born in a good condition. But then the baby was admitted to NICU after birth due to respiratory distress requiring CPAP. The baby was noted to be hypotonic and floppy, developing also stridor and noisy breathing after birth, found to have some distinctive features and having feeding difficulties. Again, this is a very non-specific picture. We know that floppy infant happens due to two big group of disorders: CNS disorders or upper motor neuron lesions, which can be chromosomal, genetic, metabolic disorders like peroxisomal, cerebral dysgenesis and malformations, hypoxic ischemic encephalopathy as well, or injuries, and the lower motor neuron or neuromuscular disorders affecting the motor neurons, peripheral nerves, neuromuscular junction, or muscles. So we needed more clinical assessment to see what does the baby, or which group does the baby fit in. This picture is not the baby's one. This is from literature, but we can see hypertelorism, upturned nose, full lips, and broad forehead. We can also see deep plantar creases, deep palmar creases on the bottom left, and the fingers and toes, especially the fingers, looked a little bit tapered and slightly maybe deviated, if we can say. There was some abnormalities here in the fingers, as we can see them in the toes. Baby's examination showed the weight and length being on lower tiles compared to the head size. Further assessment for the different problems of the baby showed here an X-ray showing some like abnormal shadows on the right upper and lower and the left lower fields of the lung. Because the baby had stridor and feeding difficulties, fiber optic endoscopic evaluation of swallowing was done. No laryngomalacia was seen, but then microlaryngoscopy and bronchoscopy was done to look for tracheobronchomalacia, and the baby was found to have mild tracheomalacia. As we can see on expiration, there is narrowing of the trachea with mild narrowing in the long segment. Echocardiography showed small PFO. Kidney ultrasound showed right-sided biliocalyceal dilatation and possible reflux with left side duplex configuration, as we can see. And prelim MRI was normal. And there was some plans to do nerve conduction and EMG, but lots of the features, the dysmorphic features, the basis of kidney abnormalities, the tracheomalacia, pinpointed that probably this is the part of a genetic syndrome, not a lower motor neuron disease condition. And doing nerve conduction study in EMG, which is minimally invasive, but still can be sometimes challenging to arrange in NICU. The plan was to do genetic testing. Again, microarray was done, which was normal. We decided to test for spinal muscle atrophy, despite the baby having dysmorphic features. Again, it's a quite simple genetic test compared to these other broad tests. And also, we kind of wanted to exclude a double diagnosis. So SM1 SMN1 deletion testing was normal, and the same for congenital myotonic dystrophy testing was normal. We decided to do rapid trio whole genome sequencing again to diagnose the baby. And this came back showing a heterozygous de novo, which means that the variant was found only in the baby and not inherited from either parents, pathogenic ERF1 variant, and it was a specific variant in the ERF gene. We know that monoallelic pathogenic ERF variants cause a syndrome called Chitai syndrome. Chitai syndrome is caused by a recurrent specific variant in ERF gene, and other variants that we can see here in the decipher on ERF gene cause variable types of craniosynostosis. Chitai syndrome does not. It's not very clear why this specific variant has a very different phenotype. This syndrome is again ultra rare, with I think 40 to 50 patients only described in literature. The main features include hyperphalangism and hallux valgus. So there is abnormalities in the finger, with abnormal extra phalanges on the X-ray, and these ulnar deviation and shortening of the index fingers. We have seen in our patient that there is some abnormalities of the fingers that was not as severe as other patients reported, and the same in toes. Patients as well have variable respiratory distress since birth, with recurrent chest infections, laryngomalacia, tracheomalacia, bronchomalacia, recurrent bronchospasm, and some patients have interstitial lung disease. And these can be quite variable between breathing independently in air to patients requiring invasive ventilation even, and not being able to wean them from ventilation. Patients have distinct features such as broad foreheads, hypertelorism, depressed nasal bridge, full lips. Again, many of the features are similar, and they have this upturned nose, similar to our patient. Other features include hypotonia, the baby being floppy, which we have seen in our patients, developmental delay, polyhydramnios, again seen in our patients, pectus, scoliosis, but there is no evidence of craniosynostosis. The patient's hypotonia improved, the patient was discharged from NICU, motor development started to catch up, and this condition is not progressive and it's not neurodegenerative. So we knew that this should happen, and then we supported the baby. The baby also is under respiratory team. Respiratory condition stabilized natally or postnatally. In examples, we can see Baker-Friedman. Fetal cleft can be caused by several conditions, but we have to remember the George syndrome, cystic hygroma in Noonan syndrome and others, echogenic bowel and cystic fibrosis, and anorectal atresia and Townes-Brooks syndrome and Vactral association among these. So at the end, early diagnosis of rare and ultra-rare genetic disorders allows for early decision-making, multidisciplinary management, and prognostication. An accurate diagnosis can help us to offer accurate genetic advice on recurrence risk, family planning options, and also prospective management of neonates at risk. And the prenatal diagnosis allows for appropriate pregnancy and perinatal management for the mom and the baby. Thank you.